Hello everyone, today we will start demonstrating surgical drains, types, purpose, history, management, insertion, removal, and evidence-based best practice. This is the overview. Again, the definition. We will start by definition. These are simply deliberate channels through which established or potential collection of pus, blood, or body fluid to be egressed and to be drained to allow gradual collapse and opposition of tissues due to many reasons. So now you will see different pictures in front of you. You don't know what is this and what is that. Later on, you will understand different types of drains. Previously, in the past, since 1887, there is someone called Alot, is a surgeon, suggested like, when in a doubt, put a drain. But this, however, elicited great criticism. And then they demonstrated the pros and cons of drains. The advantages of putting a drain in is to remove any intraperitoneal or wound collection or serum, bile, chyle, pancreatic or intestinal secretions. And also it is a signal for any postoperative hemorrhage or anastomotic leakage. And also it is a track for later drainage and anastomotic problems like anastomotic leak. However, the antagonists claim that the presence of a drain may increase the intra-abdominal and wound infections, increase anastomotic insufficiency, increase the post-op hospital stay, increase the chance of abdominal pain, and will negatively affect the pulmonary function. Types of different drains. We have very nice table demonstrating different types of classifications of a drain. According to the mechanism, we have passive versus active. According to the nature, it is just a tube or a flat sheet, and might be open versus closed, might be internally located or externally located, and the property of the substance might be inert or irritant. According to the mechanism, we have the passive drains. These are drains that act by the mechanism of capillary function, gravity, or the fluctuation of intra-cavity pressure. Like this one is a corrugated rubber drain. This one is called Penrose drain. So these are open but passive drains, act with no active energy. Active drains, these put under pressure. These are put under pressure by active suction, either high or low suction, like this one. This is called Redivac drain. And this big one called Surgivac, and this one called Jackson-Pratt drains. And this drain is available into your hospital, and you see on the ward many times. According to the position or disposition, either open or closed. Open, like this corrugated rubber drain, it is open and it is corrugated and it drains fluid on a gauze pad or into a stoma bag. and these increase the infection rate. So corrugated rubber drain, the first one and the second one, Penrose drain, these, if you have abscess and you are not worried about already, you've got an infection, so you are to put a drain in. And this drain is open and passive. Versus closed. Closed drains are formed of tubes draining into a bag or bottle, like the Redivac, like the Jackson-Pratt drain, and the chest tube as well is a closed drain. We have either silastic or rubber drain. Silastic drains are inert substances, will induce minimal tissue reaction, but the red rubber drains can induce intense tissue reaction. So this will allow a tract to form, and this will be useful, like for example, the T-tube for biliary drainage. This one is a Penrose drain. This is for a cavity, so it is open to the surface, not closed and may drain to a gauze pad, and it is not under suction, so it is passive one. And the corrugated rubber drains after closure of the sheath in grade 4 contaminated wounds. And it is used as a drainage of a superficial wound. So they are passive and they are open. There is a paper published in India in 2015 about the corrugated drain, which is inexpensive, easy to use, and readily available. It should be used in all cases of class 4, dirty contaminated surgical wounds after closure of the sheath. Jackson-Pratt drain, this is used many times, and this is closed because it drains on a bottle and it is under suction, as you see here. It will be under suction and it will be used in intra-abdominal surgery. And it's not that easy that a drain is just a tube and a bottle. It can be more complicated like this in post-operative pancreatic fistula. This is called a novel modality, and this is like a study showed that although the application of the novel drainage tube in a Whipple procedure or pancreaticoduodenectomy, there is no overall decrease of the incidence of post-operative pancreatic fistula, but there is decrease the incidence of high-grade fistula. So this will decrease severe post-operative morbidities. We will come back to our overview and we will start talking about management of a drain. But before this, we will illustrate about a purpose of a drain, which can be therapeutic, like a drain permit a exit of gases, fluid like hydrocephalus, urinary retention, abscess cavity for drainage, like radiological drainage via tube. So this is therapeutic, and also chest tube. This is therapeutic for a pneumothorax, hemothorax, or even abscess cavity as well. Palliative, it could be used as a palliative measure or palliative measure to bypass a luminal obstruction, like internal colonic stent might be called a drain because it bypasses an area of obstruction, so it's palliative. Diagnostic, like T-tube cholangiogram, is used after cholecystectomy to diagnose any retained stones in the common bile duct. And the prophylactic, to prevent operative complications in abdominal surgery, for example. And there are many specific types of drains: breast surgery, thyroid surgery, chest draining, chest surgery, cardiothoracic, biliary, thyroid, we said thyroid, and neurosurgery, and urinary catheters, and even nasogastric tubes. Here is a T-tube, and here is the radiological drainage, and here is a chest tube. We are going to talk about these in 1 minute. The radiological drainage, we have this one is a psoas abscess, and in the CT demonstrated by the black arrow, and here a tube, the white arrow, will be advanced to drain this psoas abscess, and now the tip, which is the short white arrow here, is approaching the abscess cavity. Later on, after 1 week, there is marked regression of the psoas abscess. This is called radiological guided drainage, CT or ultrasound guided. So you see here, this is a big abscess, and now it's regressed totally. Later on now, we are going to talk about chest drain, and it is demonstrated in front of you in one picture. You can put a patient in a supine 40 or 45 degrees, and then you do your incision in the 5th intercostal space, just anterior to the mid-axillary line, and then dissect, and then you use a hemostat to insert until piercing the parietal layer of the pleura, and then insert your finger, and then guide by a hemostat and put the tube posteriorly and superiorly. Simply, you have to know 2 things. You have to do a chest X-ray after putting a drain to ensure that it is in and it has treated successfully pneumothorax or hemothorax. And this is chest X-ray after the putting the drain in. And you have to see by your eyes 2 things: the bubbling, this is bubbling here, again the bubbling, and the oscillation of the fluid level, the oscillation of the fluid meniscus. Okay, so you have to see these things to demonstrate or to be sure that the chest drain in. We're going to talk about this video. I think this will be very important for you.
The first step in the placement of a chest tube is to identify the insertion site. The insertion site is the 5th intercostal space just anterior to the mid-axillary line on the affected side. This can be found by using the nipple level as a landmark for the 5th intercostal space. In females, always be aware that the nipple may be displaced inferiorly due to large pendulous breasts. In this case, remember to stay above the inferior mammary fold, where the nipple would normally lie. With the patient lying supine, position the hand up and over the ipsilateral shoulder and secure it in this position to keep it out of the surgical field. Surgically prep and drape the chest at the predetermined site of tube insertion. Using a small gauge needle, locally anesthetize the skin and subcutaneous tissue and the periosteum of the underlying rib. If possible, the pleura just past the rib should also be anesthetized. Make a 2 to 3 centimeter transverse incision parallel to the line of the ribs at the predetermined site with the number 11 scalpel. Bluntly dissect the subcutaneous tissue with the scissors or hemostat. Dissect over the top of the underlying rib until the next highest intercostal space is encountered. With the tip of the hemostat, puncture the parietal pleura while pushing just at the top border of the rib. You must always enter the pleural space over the top of the rib to avoid damaging the neurovascular bundle that lies along the groove at the inferior border of each rib. Be sure to enter the pleura in a controlled fashion to avoid lacerating the lung with the hemostat. Once inside the pleura, spread the hemostat widely and withdraw it while still open to create a sufficient opening in the pleura for the chest tube. Before inserting the chest tube, place your finger into the hole of the pleura. Move your finger around 360 degrees to confirm correct location in the pleural space by feeling the lung and making sure that there are no adhesions or impediments to placing the chest tube. A large chest tube, a number 36 or number 40 French, is used in trauma to allow for the evacuation of blood and clots. Clamp the proximal and distal ends of the tube before insertion. The distal clamp will keep any blood from rushing out before it can be connected to a collection chamber. The proximal clamp will assist in chest tube insertion, but may not always be necessary or helpful. Advance the chest tube into the pleural space to the desired length. All of the drainage holes should be well inside the chest cavity to provide a proper seal and prevent leakage. The chest tube should be positioned posteriorly and aimed superiorly in the chest cavity. This will allow for maximum drainage in the supine position. It may be possible to see fogging of the chest tube with expiration, and it may be possible to listen for improved air movement on the affected side. Connect the end of the tube to an underwater seal apparatus collection chamber.
So we have finished now with the chest tube, and removal of the chest tube will depend on clinically the patient will be improved and already the pneumothorax is subsided, or the hemothorax is subsided by two things. First, a chest X-ray post procedure ensuring that the drain is in. Second is seeing the bubbling and moving of the meniscus or the fluid level in the tube. Now we are going to talk about T-tube drains after laparoscopic cholecystectomy. Two of the known options for acute cholecystitis with CBD stones are either you do ERCP, then laparoscopic cholecystectomy within 72 hours, or a second option is doing laparoscopic cholecystectomy and at the same session, at the same surgery, you do CBD exploration, and after CBD exploration, you will put a drain in. Why? Because this will allow the bile to drain while the sphincter of OD is in spasm post-op. You can see here, you will play with your instruments here, and after CBD exploration and extraction of these stones, you will insert this T-tube here, demonstrated here. This is a T-tube, and also we'll do it here as demonstrated, okay? Lastly, about the management, and management is according to your procedure, type, purpose, and location of the drain. And again, it is not usual to be surgeon preference. You have to know that nowadays, drains are not preferred unless necessary, and a written protocol from the surgeon or from the main consultant and registrar can help the staff on the ward with the post-op care of a surgical drain. If active, the drain can be attached to the suction source, and a set or a pressure specific at any pressure can be prescribed, and the drain should be secured because dislodgement is likely to occur when transferring patients after recovery. And recording of the drainage is very important, and like you have to follow the changes in character and volume of fluid. Like for example, when you do appendectomy and you decided to put a drain in, and after the surgery, because it was dirty and the appendix was sloughed, so you put a drain in. After you see Postoperative day 2, you found a fecal matter in the drain. This means that the cecum or the appendix space is perforated. So you must keep eyes on the drain character of the material, and also amount should be recorded daily. And also this will help in fluid loss guide. Removal should be removed as early as you can, and this is one of the enhanced recovery program items. Again, it's not about number like 25 ml per day, because always your body secretes amount of serous fluid. So if you will not remove it, or if you decided to remove it after this number, which is 25 ml per day, you will never remove it. So drains can be removed once you feel that now the patient is feeling well, the inflammatory markers are improving, the amount is gradually and stably decreasing, so you can remove it safely. And you can put analgesia, you can put a dry dressing, you can consider the need for what's called early drain removal, and simply again and again. If you feel the drain is not in place, remove it. And again, don't leave drain as much as you can, because the benefits of leaving drain more is less than removing the drain earlier. Evidence-based medicine. We're going to talk about evidence-based medicine that many gastrointestinal operations can be performed safely without prophylactic drainage. And drains should be omitted after hepatic, colonic, rectal resection with primary anastomosis, and appendectomy at any stage of appendicitis. Because there is a retrospective review found that even the complicated appendicitis with secondary peritonitis and sepsis in the modern era of antibiotics does not necessitate the use of prophylactic drain placement, which at times may even prove counterproductive. Pelvic drain may act as an early detector of anastomotic leak and reduce the need for reoperation in selected patients undergoing rectal cancer surgery. Again, pelvic drain can be early detector of anastomotic leaks, but this is again is considered level 5, and because some people think, or some surgeons think, that the leaks usually occur after drains have been removed. So again, the drains now is of no value. So just the review of randomized controlled trials, that again, drains are not required in colorectal, liver, and pancreatic surgery, and yet in today's practice, the majority of surgeons will still utilize drains, and this is not correct. Again, there is insufficient evidence showing that routine drainage after colorectal anastomosis prevents anastomotic leak and other complications. After lab chole and after open cholecystectomy, lab or open cholecystectomy, evidence support the use of a drain is not recommended. The only area of the GIT you can use a drain in is esophageal, and again, this is evidence level 5 and is evidence on expert opinion, so it is not also recommended. Again, the overall of our discussion today is please don't put a drain unless necessary. And put it in the correct position, not to be like this. Thank you so much.